Okay, everybody. I just realized I did this entire presentation and didn't press the record button, but I'm still in the hospital with my husband. He's out of ICU now in a regular unit, but we're at Loyola. We'll probably be here for a few days. So I decided to make this presentation, record it so that you'll have it to study from for your exam. The exam will be opened on Tuesday and will remain open through Thursday. You must use your Respondus as a security measure. All right, so let's get going. They're going to be renal, GI, endocrine, neurologic, and reproductive concepts on this test. So remember, we don't give out test questions where we talk mainly about concepts, right? Concepts that are going to be on the exam. And in doing this, I broke this up and I put three, well, I call these like sections. Okay, so there can be 3 or 4 sections that we're going to talk about on each slide. And if you have any questions, I know it says speak up as we go, but because I had originally intended to do this as a lecture using Zoom. But if you have any questions, you can please text me those questions and I'll do my best to answer them for you. Okay? Now, when you're looking at the kidney, always think creatinine rising means kidney injury. Creatinine's cleared by filtration, so anything that lowers the filtration raises it. It generates lots of questions when you have this happening, so don't make too much out of it. Just remember that when the GFR is elevated, something is going on. All right, so let's see. Yeah, let's go to the next one. All right, so these are the concepts that are going to be covered on the exam. Talked about that. And in the renal system, one question drives almost everything. And we talked about the glomerular filtration rate and why. Every consequence, creatinine, potassium, anemia, bone disease, all are related to the glomerular filtration rate. The GI tract, think of the 4 failure modes. A barrier's not working. Something obstructs. An accessory organ's not working properly. Endocrine, 2 concepts. There's either too much or too little, and it's always hormone related. Neurologic, perfusion, pressure, electrical activity, and structural loss of neurons or myelin. Nearly every question is going to land in one of those 4 concepts, we'll call them. The reproductive system, hormonal imbalance, tissue in the wrong place, inflammation that leaves a scar, or enlargement that obstructs the view. Or the flow. So if you can, I don't want to say memorize, but if you can recall these 5 big ideas, you're going to do okay. We're going to start it on the renal system. And let's start from the beginning a little bit, okay? The main job of the kidney is to filter waste, regulate fluid volume, balance electrolytes and acid base, produce erythropoietin, and activate vitamin D. So the kidney filters, balances, secretes, and kidney disease is the loss of one or more of those 3. And we're going to talk about acute injury versus chronic injury, systemic effects of chronic disease, and the nephrotic versus nephritic distinction. Acute kidney. Now, with acute kidney disease, the anchor is creatinine. This is the clearance marker. It's produced steadily by muscle, so the blood level reflects how well it's being filtered out. If filtration falls, it accumulates. And that that logic is translated through the glomerular filtration rate. And the GFR moves in the opposite direction of creatinine. So if you ever see that there is a question about the GFR and the creatinine, they should always be moving in opposite directions. Don't ever say they move in the same direction. There are three main categories: pre-renal, which is something that happens before it gets to the kidney. Pre-renal can include volume loss from vomiting and diarrhea, hemorrhage, burns, or poor forward flow, like in kidney failure. So the kidney tissue initially is fine. It's starved, it's not damaged. So it's fixable, right? We give fluids, it gets hydrated, it's all good. Then there's intrarenal, damage to the tissue itself. Nephrotic drugs and contrast injuries injure the tubules. Immune-mediated inflammation injures the glomerulus. Prolonged pre-renal ischemia eventually becomes intrarenal injury, so you do need to correct it. Post-renal is obstruction, and this is a concept most students will miss. If you have two functioning kidneys with only one being obstructed, you're rarely going to see creatinine change much because the other kidney will compensate for the one that's not working properly. With bilateral obstruction or obstruction below the bladder, it's going to be what raises. Now let's put it together. You give fluid to stop pre-renal, stop the offending agent for intrarenal, relieve the blockage for post-renal. And the wrong move in the wrong category is going to make things a lot worse. So a patient has 3 days of vomiting and diarrhea and now almost has no urine output. Where's the problem? It's pre-renal. We're going to increase the volume by restoring it with an IV of normal saline so that we can rehydrate that patient is suffering from dehydration. Acute versus chronic kidney disease. Students often mix up these two. So acute kidney disease usually has got a findable precipitant. So what changed in the last few days? Chronic kidney disease has a trajectory instead of an event. So over the past several months or long-standing, think chronic. Is it reversible? In acute kidney injury, correcting the cause can restore the function. In chronic kidney disease, the nephrons are gone and they don't come back. So the management is targeted to slowly reducing further loss and treating downstream consequences. We want to make sure that those surviving nephrons hyperfiltrate to compensate, which is why substantial function can be lost before creatinine rises noticeably. That's one thing that you're going to see with the kidneys. They are quite adaptable. They will, I mean, you have two of them, and they're going to do their best to try and keep the numbers up, even if one is totally out of service. So acute and chronic essentially are both about filtration. If both drop the GFR, why does one patient get better and the other doesn't? Well, the answer is related to whether or not the nephrons were starved or destroyed. Acute kidney injury does not always progress to chronic kidney disease. It can, particularly with repeated or prolonged injury, but it's not an automatic. All right, so chronic kidney disease, it's not just a waste clearance problem. The kidney is also an endocrine organ, and complications that follow are what make patients sick. So with chronic kidney disease, what can happen? The patient can develop anemia. They have low hemoglobin. The marrow is not stimulated because erythropoietin is low. The cells that make it are gone. And And look, when you're looking at it the whole, inflammation is not enough to cause anemia. This is a production failure, not enough erythropoietin. Hyperkalemia. Potassium leaves the body mainly through the kidney, and fewer nephrons means less excretion, so it can accumulate. Potassium intake and potassium-sparing diuretics and certain antihypertensives need to be used in extreme caution with chronic kidney disease. That's why hyperkalemia is a classic dialysis indication. Cardiac conduction affects as the reason it's urgent, but not just abnormal. So potassium decrease can cause cardiac arrhythmias for sure. Bone disease. Now, this is a more complex, not that these all are not complex, but this is, I think, the most complex. You have a failing kidney, results in less activated vitamin D, less intestinal calcium absorption, and the serum calcium falls. If you have a failing kidney, less phosphate excreted, serum phosphate rises. Low calcium and high phosphate causes parathyroid hormone to rise. This is called secondary hyperparathyroidism. Calcium's pulled from the bone and causes it to become weak. So which of these three would you expect to appear first, and which is the most immediately life-threatening? Well, bone disease develops slowly. Hyperkalemia, it can kill you today. So that would be our priority. So if you were a nurse or a provider at the bedside and you were looking at labs on this patient, what would be the most critical? Potassium level, right? So potassium is super important, especially in patients with renal disease. I'm sorry if you're hearing beeping in the background, but I tried to find a quiet spot here. Nephrotic nerve versus nephritic. The glomerulus is like a sieve. Nephrotic means the holes got bigger and let protein through. So remember that analogy. Nephritic means the sieve is inflamed and damaged, so whole cells escape. With nephrotic syndrome, well, I call it nephrotic syndrome, you have massive proteinuria, and the defining feature is, let's see, massive proteinuria, which is protein in the urine. It's the defining feature. The rest of the syndrome follows from losing albumin, which is protein. So why is a glucosuria wrong? Because that's a tubular reabsorption issue driven by hyperglycemia. And hypercalcemia is wrong. No mechanism links it here. That's a distractor. So only remember that edema follows the oncotic pressure. If you're losing protein, you're going to have a lower plasma oncotic pressure. So fluid that would be in the vessel moves into the interstitium. Generalized edema is a direct consequence of the protein lost, not sodium wasting. So these are the patients that are going to get periorbital edema around their eyes, swollen legs, and it's very concerning. Nephritic inflammation, it damages the filtration barrier, so red cells pass, producing hematuria or blood in the urine. You may see proteinuria, which is protein in the urine as well, hypertension, and reduced urine output. So protein equals nephrotic, blood equals nephritic. Now, not all patients with blood in their urine or protein in their urine have these specific syndromes. We're talking about patients who have kidney disease. Now, later on, we're going to be talking about ascites, which is the accumulation of fluid in the abdomen. And this occurs in patients who have oncotic pressure issues. The reason is a little different. in that, but we're going to talk about that in a little bit. So the patient has frothy urine and swelling around the eyes. Which syndrome and what's the single lab you want? Nephrotic and urine protein. Remember that. Swelling around the eyes. All right, let's talk about GI fails. So there are primarily 4 different failures that occur in the GI tract. Protective barrier fails, and this occurs in reflux, peptic ulcer disease. Inflammation follows a characteristic pattern like in Crohn's disease. Number 3, something obstructs like biliary disease. And number 4, an accessory organ. What is an accessory organ? Accessory organs are the stomach, the liver, the pancreas loses their function. So if the pancreas isn't functioning properly, it cannot secrete digestive enzymes that aid in the digestion of food. So I really want you to focus on the difference between Crohn's disease and ulcerative colitis. And I've got a slide that's going to talk about these 2 conditions exclusively. Also, I want you to highlight the acid-base link. So GI losses change the pH, and that connection is often tested at which disturbance item. So acid-base link can be greatly associated with GI losses because it changes the overall pH in the system. Upper GI, barrier failure and acid. So let's think about the anatomy. You have your mouth, and then you have your throat, your esophagus. Your esophagus then connects to your stomach. There is an esophageal sphincter that is supposed to be tight around the top of the stomach that keeps the acid tolerant stomach acid in the stomach from getting into the acid intolerant esophagus. Many people suffer from a relaxation of that valve, and acid refluxes up into the esophagus where it's not supposed to be. So this is different from a pyloric sphincter. So I want you to think back to anatomy. The pyloric sphincter is the sphincter that connects the stomach to the small intestine, or the duodenum, which is the first part of the small intestine. Don't confuse that with the valve that connects the esophagus to the stomach. Now, chronic exposure of the stomach to the stomach acid can cause metaplastic changes. So it can cause changes to the cellular structure of the esophagus. For example, Barrett's esophagus, which are precancerous cells, and it's caused directly by that acid in where it's not supposed to be. All right, peptic ulcer disease. There are certain conditions that contribute to the development of peptic ulcer disease. Acid, pepsin, H. pylori, which is a bacteria that causes them, and non-steroidal anti-inflammatory use. There are also defensive factors in the stomach, like the mucus layer, bicarbonate, which helps to keep that acid level normal, mucosal blood flow, prostaglandins. So H. pylori tips the balance by promoting inflammation and impairing those defenses. So this bacteria is not simply making more acid, it's degrading the protection. Non-steroidals work on the same balance from the other side. So if you take a non-steroidal anti-inflammatory like ibuprofen, it reduces prostaglandin-mediated defense. So if you're taking that, it is reducing your stomach's ability to protect itself with the mucus. Vomiting an acid base, so gastric fluids rich in hydrogen and chloride. If you're vomiting, you're literally removing the acid, so your blood is going to become alkalotic. And metabolic alkalosis typically occurs with hypochloremia and volume depletion. Now, with lower GI losses from diarrhea, you're going to lose bicarbonate-rich fluid. So it tends more towards a metabolic acidosis. So put those side by side. And I want you to remember the difference between acidosis and alkalosis as it is considered in the GI tract. Okay, let's talk about the difference between Crohn's disease and ulcerative colitis. One of the concepts that you're going to discuss is that Crohn's and ulcerative colitis, the difference is the location. Crohn's can appear anywhere along the GI tract. It can skip lesions, normal tissue between diseased tissue. Ulcerative colitis is confined to the colon. It begins at the rectum and marches proximally without gaps. The anchor phrase is Crohn's skips, colitis is continuous. Crohn's is transmural. Ulcerative colitis is mucosal and submucosal. What does that mean? You can predict complications from the depth alone before you reveal the third consequence. Before we get to consequences, full thickness inflammation can burrow through the wall, hence causing fistulas, connecting bowel to bowel, bladder, or skin. It can heal with fibrosis. It can narrow the lumen, causing strictures and obstruction. Superficial inflammation instead denudes the mucosal surface, which bleeds, so bloody diarrhea and urgency dominate. Now, you don't need to memorize a list of complications. All you need to consider is the depth and location. Inflammation limited to the rectum or continuous. And students often will choose Crohn's because they associate Crohn's with severity. Severity is not the discriminating pattern here. So don't think that way. Fistulas between the small bowel and the skin, which disease? Crohn's disease, because it's transmural and inflammation can penetrate the entire wall. Now, what is a fistula? You may not know what a fistula is, but it is a tunnel of sorts. So this tunnel can be created between the bowel and it can go all the way through the skin, so you can actually have a little hole on the outside of your skin that stool will escape from. You can have fistulas in the bladder as well, where urine will escape. And they can be very dangerous. They can cause, ultimately become infected and cause death. I had a friend of mine who had cancer, and ultimately that's what she died from, of an infected fistula. All right, next slide. All right, celiac disease. The mechanism of celiac disease is immune-mediated injury to the small intestinal mucosa, and it occurs in response to gluten, producing villus atrophy. So what does that mean? I want you to consider a shag carpet. I don't even know if you know what a shag carpet is, but it's carpeting that has very long fibers, say like an inch long. So consider a shag carpet and a tile floor. Villi enormously amplify the surface area, and flattening them destroys their absorption capacity. So this is not an obstruction and not an enzyme deficiency when you're looking at this, at celiac disease. And the loss is structural. The deficiencies are broad. So the patient can have iron deficiency anemia, fat-soluble vitamin deficiency, folate deficiency, weight loss, steatorrhea, which is bloody diarrhea. They can all appear. The breath is the diagnostic clue. A single missing nutrient suggests a specific transport or intake problem. And a lot of references suggest a surface area problem. And segment matching. We want to incorporate this habit into our practice. The habit of mapping a symptom to the segment. So esophagus and stomach for acid and reflux, small intestine for absorption, colon and water handling, and inflammatory bleeding. So a patient has chronic diarrhea, weight loss, and a low iron despite adequate intake. Which segment and what's happening to it? It's the small intestine. There's an absorption or an absorptive surface damage. The liver. Um, the What is biliary obstruction? Well, the liver has different bile ducts, and bile is excreted through these ducts. Sometimes an obstruction can occur. So biliary obstruction is one. Bile is made in the liver and it must drain into the intestine. A block of the common bile duct can cause conjugated bilirubin to back up into the blood and tissues, producing jaundice, which is a yellowing of the skin. It can also cause dark urine and pale stools. The reason for that being is that bilirubin is the primary component that colors our bowel movements. And if it is not reaching the intestine, that pigment will not be there. Hepatocyte failure. It can be a drainage problem with a healthy liver. So it can be an obstruction. I've had patients who have gallstones that are stuck in the bile duct. Let's look at another concept here. Portal hypertension. Fibrous scarring and regenerative nodules distort the vascular architecture, so resistance rises and pressure builds upstream in the portal system. So esophageal varices, which is essentially varicose veins in the esophagus. So esophageal varices from collateral flow, splenomegaly from congestion and ascites. Ascites is an accumulation of fluid in the abdomen. And let's see, our next condition we're going to talk about is pancreatitis. Normally, enzymes are activated in the duodenum. The duodenum is that piece that comes directly off the stomach. They activate early inside the pancreas, and the gland autodigests. So that explains the severe pain and systemic inflammatory response. Pancreatitis is incredibly painful. We need to correct the common distractors. It's not autoimmune destruction of hepatocytes, and it's not a gastric acid problem. Cirrhosis does more than raise the pressure. It stops the liver from making things. And that combination is what produces ascites. So patients with liver disease or liver failure often have ascites, which is that swelling in the abdomen. So ascites, we need to know what the mechanism is. Most students get this one wrong. The liver is both a filter, and so blood must pass through it. And it's also a factory that manufactures proteins. Cirrhosis breaks both, and the classic complications come from combining them. There can be a blocked flow. Some mechanical point, as the previous slide, like increased resistance, increased upstream pressure on its own, high hydrostatic pressure pushes that fluid out of the capillary bed. Or it can be loss synthesis. The liver manufactures albumin, which is protein, and clotting factors, which makes the blood clot. Less albumin means less oncotic pull, holding fluid inside the vessel. Fewer clotting factors means that the bleeding risk of the patient goes up, and that's a dangerous combination with varices, which are those varicose veins in the esophagus. So think about what can happen if those varicose veins were to burst. Now, ascites, which is that fluid in the abdomen, requires both pressure pulling fluid out and insufficient oncotic pressure to hold it in. Then add sodium and water retention from the resulting reduction in effective circulating volume, which worsens the accumulation. Explicit callback to the renal block nephrotic syndrome also lowers albumin, but through urinary loss rather than failed production. Some consequence, edema, arrived at by different routes. So what do you think? Both routes are out loud. What do you think? Say it to yourself. So increased albumin and it decreased portal pressure. Think about those concepts and answer those questions. The endocrine system, we're halfway there. There are a lot of pieces to the endocrine system. The hypothalamus accounts for the pituitary, which releases a stimulating hormone, which goes to a target gland, which releases the effector hormones and causes a negative feedback loop back to the pituitary. So it determines how much it needs so that it is supposed to be at an equilibrium or homeostasis. So there are two questions or two items that cause most endocrine problems, and it's pretty simplistic. There's either too much or too little, or the problem is the gland. Something isn't signaling properly in the gland. So there's always a stimulating hormone and a target hormone. So think of that together. Something stimulates the hormone to release a target hormone. Now, diabetes is two distinct diseases. It's primary versus secondary rule. Thyroid and adrenal disorders and ADH, antidiuretic hormone-driven water balance. And we'll speak about these things in more detail. Here is type 1 autoimmune destruction of beta cells produces an absolute deficiency. So in type 1 diabetes, there's an absolute deficiency of insulin. Exogenous insulin is required from the start, and the onset is typically abrupt, often in younger patients. Type 2. Resistance tissue responds poorly, so beta cells secrete more insulin to compensate. Blood glucose stays controlled for years while insulin levels are high. Eventually, the beta cells cannot sustain that output and glucose rises. So it's a progressive condition. It explains why treatment escalates over time and why the disease is not static. DKA. Let's look at the chain. Build the chain and let's say it to ourselves. No effective insulin, so glucose cannot enter the cells. The cells are energy starved despite high blood glucose. The body breaks down fat, lipolysis, to release free fatty acids, which reach the liver, converts them to ketone bodies. Ketones are acids. Metabolic acidosis occurs. Now let's look at the clinical picture of this patient. Patient in diabetic ketoacidosis. They have hyperglycemia, which causes osmotic diuresis, so dehydration and electrolyte loss accompany the acidosis, and the respiratory system compensates with deep, rapid breathing. And these patients will often have an odd smell to their breath. It smells fruity, and that is acetone being exhaled. So cells are starving in the middle of plenty. So remember that. Why does DKA occur in far more or occur far more readily in type 1 than type 2? And that's because residual insulin production substantially suppresses lipolysis. So type 2 patients often generate that degree of ketone production. All right, primary versus secondary. So let's reconstruct the logic rather than just reading the slide here. If the thyroid fails, T4 is going to fall. Falling T4 removes that negative feedback on the pituitary, so the thyroid stimulating hormone rises. The mismatched pair, low target hormone, high stimulating hormone, points to the gland. If instead the pituitary failed, it could not raise TSH, so both values would be low. So let's practice this. I want you to say this out loud as you're reading it. Low T4, high TSH. Where's the problem? low T4, low TSH. Now where's the problem? Graves' disease is a useful case because autoantibodies stimulate thyroid stimulating hormone receptor directly, bypassing the normal regulation. Hormone output rises without the pituitary asking, so the gland is overactive, while TSH is suppressed by feedback. And so the immune system is imitating the signal. How are the adrenals affected here? Primary insufficiency means that the adrenal cortex cannot make enough cortisol and often aldosterone as well. Cushing's syndrome is the mirror image, prolonged excess cortisol exposure regardless of the source. So one value when you're talking about hormones is a clue. Two values are a diagnosis. So they work in concert together, either good or bad. And there's a lot of information on this slide that you'll find beneficial. All right, thyroid and adrenal going on. All right. Hyperthyroid, the thyroid hormone sets the metabolic thermostat and increases sensitivity to sympathetic signaling. So turn the thermostat up. The heart rate rises, heat's generated, so heat's poorly tolerated. Calories burned faster than they are consumed, so weight drops, and the nervous system runs hot with anxiety and tremor. So think about those things with someone who has hyperthyroidism. Hypothyroidism, we're going to turn the thermostat down. Everything reverses. Heart rate slows down. Cold intolerance. Sluggish gut, so they get constipated. Tired all the time with weight gain. And adrenal. Cortisol supports the stress response. Blood pressure and glucose availability. Too little cortisol means poor tolerance of physiologic stress, fatigue, hypotension, often with electrolyte disturbance. When aldosterone is also deficient, too much sustained over time, it produces the elevated glucose breakdown of muscle and connective tissue, central fat redistribution, thinned hair, and suppressed immunity. And there can be drug-induced cortisol excess. If someone is taking glucocorticoids like steroids for therapy, it produces the same clinical picture as someone who has that syndrome. So they will get all of the symptoms of someone who has that too high cortisol. Okay. Antidiuretic hormone regulates water absorption in the kidney. It doesn't move sodium. So sodium abnormalities in these conditions are concentration effects. Think about that. Hold water and sodium looks low. Lose water and sodium looks high. The total body sodium is not the primary problem. SiADH, too much ADH means that the water is reabsorbed when it should not be. Plasma is diluted, so serum sodium and serum osmolarity fall, while the urine is inappropriately concentrated because that fluid is going into the circulatory system, not going through the bladder, or the kidneys rather. Symptoms follow from dilution and cellular swelling. It cause headache, confusion, and seizures. Diabetes insipidus. Either the pituitary doesn't release enough ADH or the kidney can't respond to it. Water's not reabsorbed, so the patient produces enormous amounts of dilute urine. They're very thirsty and can develop hypernatremia if intake does not keep pace. Confusion is one of the symptoms. It has nothing to do with blood glucose or insulin. The shared word diabetes refers to the polyuria, not the mechanism. So diabetes insipidus, actually, it has nothing to do with diabetes. All right, hypernatremia from water loss is attached to SIADH, and it is the correct mechanism for DI wearing the wrong label. Diabetes insipidus wearing the wrong label. Exactly the kind of distractor that punishes things, memorization of when you're trying to study for an exam. So you don't want to look at those distractors. Just look at the concepts. I keep, wanting to refer to the concepts because they're so important. All right, let's see. I've got to redo this one. Okay. So let's look at the neurologic system. The brain sits inside a rigid skull. It's got a fixed volume, a very high metabolic demand, and almost no capacity to store or regenerate. It has no capacity to store energy and cannot regenerate neurons. So the themes we're going to want to remember for this system: perfusion, pressure, electrical activity, and structural laws of neurons or myelin. So we're going to look at strokes and intracranial pressure, an ischemic versus hemorrhagic comparison, degenerative and demyelinating diseases, and seizures, meningitis, and spinal cord injury. Okay, so let's look at strokes first. There are two types. Ischemic versus hemorrhagic. Ischemic is because of an occlusion. Hemorrhagic is caused by a rupture. So there's bleeding in the brain. And they both it has to be identified because they're treated differently. Okay. Perfusion of the brain depends on the difference between the pressure pushing blood in and the pressure inside the skull resisting it. So there's a relationship like as a subtraction on a board. Perfusion pressure equals mean arterial pressure minus intracranial pressure. What happens to perfusion is intracranial pressure climbs while blood pressure stays the same. Well, this explains why intracranial pressure is very dangerous even when the blood pressure looks normal. The skull's rigid, adding volume, blood, edema, tumor, excess cerebral spinal fluid, all can cause increase in intracranial pressure. Once that compensation is exhausted, rising pressure reduces perfusion, which can cause more injury and then more edema. It's a very vicious feedback loop. Intervention is critical. A progressive decline in the level of consciousness is the earliest reliable indicator of deteriorating cerebral function. Dramatic vital sign changes tend to be late. So I have found that our body has a really fascinating way to compensate for conditions that occur. Once that compensation or compensatory mechanism has exhausted itself, things go bad very, very quickly. So it's so important to identify things. So let's use a patient that's difficult to arouse. More difficult than it was an hour ago, but the vital signs look good. Is this a reassuring sign? Absolutely not. This is exactly what worsening intracranial pressure looks like. And remember that example I said in class about the patient I had who had been involved in a motor vehicle accident and had a subdural hematoma. All right. Let's look at ischemic versus hemorrhagic strokes. They can present with identical looking presentations, but they've got totally opposite mechanisms. And that's why imaging comes before treatment. Hospitals, fortunately, decades ago, instituted new programs into the emergency room where if a patient meets certain criteria, a stroke alert is identified and they immediately get a CT scan of the head. It's incredibly important to determine if this is an ischemic versus hemorrhagic stroke because the mechanism of action is totally different. As I said before, ischemic is a blockage, something is occluded by a blood clot. A hemorrhagic is a rupture of a blood vessel and blood is escaping. Now, we normally will give patients clot busters. if they have an ischemic stroke. And fortunately, that will get in there and help to dissolve that clot. The faster it's initiated, the more likely there are to be fewer untoward effects from the patient. And a hemorrhagic stroke, totally different surgical intervention ASAP. All right. So time is of the essence with these. So getting blood restored helps in reducing the long-term effects that can occur with speech, mobilization, etc. Both of these conditions present with sudden focal deficits. So what history can raise suspicion over another? Let's think about this. I'm always concerned with patients who come in with abrupt severe headache. They might have known vascular conditions, high blood pressure. So it's very important to rule out stroke in any patient that comes in with a severe headache. I do a very thorough neurologic check on all of my patients who come in with that diagnosis or with that symptom. Degeneration and demyelination. So let's look at these in different categories and what's lost: Parkinson's, multiple sclerosis, and Alzheimer's disease. Parkinson's disease causes the loss of a specific population of neurons. Multiple sclerosis loses that myelin sheath, and Alzheimer's loses neurons diffusely with characteristic protein deposits. Let's talk briefly about Parkinson's disease. Dopaminergic neurons in the substantia nigra degenerate, and the basal ganglia lose the dopamine input that smooths and initiate movements. So these patients will present with resting tremor, rigidity, lack of facial expression. They may shuffle when they walk. Multiple sclerosis. Imagine an electrical cable. Myelin is the insulation that lets signal travel quickly through. This is immune-mediated damage that slows or blocks the conduction because lesions can occur anywhere in the CNS. The symptom picture is highly variable. It often starts with visual changes, weakness, numbness, coordination problems, and a lot of patients relapse and remit as inflammation flares and partially resolves. There's some really good medications out there right now for multiple sclerosis. Alzheimer's disease, extracellular beta amyloid plaques and intracellular neurofibrillary tangles of abnormal tau accompany progressive neuronal loss and synaptic failure. These often present with recent memory and expand into language, judgment, and function. Dopamine excess isn't the mechanism. That distractor appears regularly, but it's not causative. Patients with Alzheimer's disease can often remember things that happened decades ago, but cannot remember what they had for breakfast. Seizures, infection, and cord injury. So let's look at these different seizures. They're an electrical event. Abnormal excessive synchronous neuronal discharge. So you've got all these neurons shooting off at once. The patient, how the patient looks is dependent on where these, I like to think of them as fireworks, where the fireworks start. Focal activity produces localized findings, and generalized spread produces loss of consciousness and bilateral motor activity. There are many different kinds of seizures, but they all have the same mechanism of action. Bacterial meningitis. This is an infection of the meninges. It provokes intense inflammation of the covering and adjacent structures. A lot of the injury comes from inflammation. The edema raises intracranial pressure and causes impaired perfusion. So think back, you've got a closed skull, you can only fit so much in there. Meningitis is going to cause that lining to swell, and it can cause brain damage. Typically, it presents itself with a severe headache, fever, neck stiffness. Spinal cord injury. The effects of the spinal cord injury are certainly related to where the injury is. If it is at the level of cervical cord, you're going to have respiratory issues. The patient will not be able to breathe unless they are ventilated. A high cervical injury can interrupt the control of that ventilatory reaction, and so the level of energy is going to predict the respiratory risk. And the cervical injury, airway is number one. Got to keep that airway open. So mainly, just remember, the level of injury dictates the severity of the injury. The reproductive system. The 4 patterns of hormones, ectopic tissue scarring, and obstruction. All right, PCOS. That is polycystic ovarian syndrome. The defining combination is hyperandrogenism. So the patient may have hair, facial hair, infertility, insulin resistance. Patients with PCOS often will have irregular or absent cycles, infertility, androgen-related findings like hirsutism and acne. We want to correct the distractor of severe estrogen deficiency in all patients. Endometriosis, this is endometrial-like glands and stroma outside of the uterine cavity. They respond to hormones, so they proliferate and bleed within the cycle. It can cause extreme pain and produce fibrosis and adhesions and infertility, because these tissues may extend to the fallopian tubes or the ovaries, causing an impairment in their ability to function properly. PID is pelvic inflammatory disease. This is an ascending infection, often caused by recurrent sexually transmitted infections. It can cause scarred, narrowed tubing, impair the transport of the ovum, and cause infertility. All right. BPH, testicular torsion and cervical cancer. BPH, this is in men. Prostate. Pure mechanisms, the prostate. It surrounds the urethra, so enlargement narrows the channel, raises resistance to outflow. So men often, as they get older, produces hesitancy, weak stream, they can't empty completely, and eventually retention. Testicular torsion, very, very painful. It's a twisting of the spermatic cord. It compresses the lower pressure veins, causes swelling, extreme pain, ischemia. If the flow is not restored, it will, the patient will lose their ability to create sperm. And it is considered a surgical emergency. Cervical cancer, persistent infection with high-risk HPV types is the dominant etiologic factor. So persistent transient infections. What people don't realize is that people who have HPV, it may often go away on its own, but there are some, like 16 and 18, there are many, many, many different types of HPV. 16 and 18 are the ones most likely to cause cervical cancer. So repeated exposure to these two genotypes increases your risk of developing cervical cancer. Menopause, and it's the primary event of ovary progressive depletion of functional follicles. So when you're born with all of the eggs you're ever going to have in your life. And every month, one prepares itself to break forth the corpus callosum and try to become fertilized. But once you get to be in your late 40s, early 50s, you run out of eggs and that stops. Then there is a feedback rule. Less follicular function means less estrogen. Less estrogen means a weaker negative feedback on the pituitary. So FSH, or follicle stimulating hormone, rises. And low estrogen and high FSH is the expected postmenopausal pattern. This can cause irregular menses, it can cause extreme bleeding, it can cause hot flashes, all of those wonderful things that happen. Now let's look at ectopic pregnancy. An ectopic pregnancy is when a pregnancy implants in the fallopian tube. This is also a medical emergency. Most of these cannot be, you must go in and remove the tube, because if that tube were to rupture, it can cause life-threatening intra-abdominal hemorrhage. So early recognition is critical. In the emergency department, every woman of childbearing age that comes in with an abdominal pain is considered ectopic unless proven otherwise. So that's why many patients come in and right away we're doing a pregnancy test on them in the emergency department, because that needs to be ruled out. All right. So take a peek at this slide. This slide's going to be really helpful for you to memorize, or not memorize, but know certain concepts that are going to be on the exam. Don't confuse values or where they should fall. Remember the glomerular filtration rate. All of those things that we discussed today. Be able to explain 5 core mechanisms, practice reasoning forward and backward, and bring your questions to office hours, which for me is 24/7. So you come to me whenever you have any questions at all. And I'm going to take a peek at something real quick.